Hello everyone, so this is our Chapter 7 lecture on depressive and bipolar disorders. We may have heard these terms used frequently, or maybe have struggled with some of these issues ourselves, and so what we're going to do today is just go over that diagnostic criteria for each of the disorders and focus on how we think these disorders develop. I think that should be the main focus of this lecture, in trying to condense these videos. I'm really trying not to give you all too many videos, but I get a little carried away. So let's get started. Depressive and bipolar disorders. We're going to look at unipolar depression and bipolar disorders. So think of that as looking at two ends of the spectrum. Unipolar, you're experiencing the depressive symptoms. Bipolar, you go from mania to depression, and we're going to discuss what those are. A little bit about suicide, because it is a symptom of depression, and it doesn't always have to be present when someone has depression, but it's important to understand what it is, some of the warning signs, because it does tend to occur with depression. And making sense of all that is known, so just looking at how this develops throughout someone's life. I've incorporated this video into our slide, and I think it's really important because in a time where mental health is seriously being questioned with the quarantine and lack of socialization and the life, as we knew it, Dr. Tracy Marks provides us a little insight on what's the difference between feeling depressed, like having, feelings toward a certain scenario, especially the pandemic, versus having depression as a diagnosed disorder, because sadness and depression are not the same. Which that may be a test question. Who knows on our little quiz this week. But depression and being sad are not the same. Having emotions are very circumstantial. They're ending when something has passed. And they're time bound. They're a response to something. Whereas depression is just this prevalent negative hopelessness, extreme sadness, lethargy, anhedonia that occurs as a result of something deeper that's going on than, situational triggers may, start it up. But there is something else going on we have to investigate. So check out that video in your slideshow. Let's look at the symptoms of depression, because we kind of have an idea of what it is. But it's really, I had one professor tell me in college that it's a disease that lies to you. In abnormal psychology, depression, your thinking patterns are altered. It affects so many different facets of your well-being, your emotional symptoms. It has motivational symptoms, behavioral symptoms, cognitive symptoms, and even physical symptoms. So we're going to run through those really quickly just to make sure we understand that, depression is more than the emotions, right? There's loss of pleasure in things that someone once found pleasurable. There's anxiety, there's anger, there's agitation. Remember, this can be comorbid with anxiety disorders or other, substance abuse issues. Motivational symptoms, so you don't really feel the need to do anything. You're not inspired. Low desire to pursue educational activities or lack of drive in really anything. And these emotional and motivational symptoms, they can build up on themselves to have these behavioral symptoms where we see that the person is not as active. Maybe they're laying in bed all day. They're less productive, right? They're ignoring things that they quote unquote have to do, right? And just kind of lazing about because they don't have that motivation to do something. We also have cognitive symptoms. So thinking patterns are quite altered in the brain of someone who's struggling with depression. There's extreme negative views and pessimism tend to be prevalent in these people, as well as low self-esteem and self-efficacy. And these are different in that self-esteem is going to be kind of how you feel about yourself, okay? And self-efficacy is how well you think you can do something. I think that's the best way to differentiate it in a nutshell. But it's going to affect how we perceive our self-esteem and our self-efficacy. We kind of think extreme negative views about ourselves and kind of think we can't do anything. It starts lying to us, and it's kind of reinforcing in that way. And maybe we think we can't do something. We don't try it. And then it kind of reinforces the idea we can't do it because we've never tried it. So again, it lies to you. There's also physical symptoms. Sometimes depression can manifest in older people as physical symptoms because we found, people of younger generations are more open and there's less of a stigma tied to discussing psychological disorders, whereas older generations, there's still very much a stigma. And so sometimes depression can present itself in physical ailments, so pain, indigestion, headaches, dizziness. Our mind-body is connected, and so sometimes you've had this happen in any circumstance where we've thought something embarrassing and maybe get a little knot in your stomach. It's kind of like looking at depression. Think of an extreme form of that, right? Our psychological state is affecting our physiological state. Trigger warning. Please note that moving forward, our lecture will discuss depression, suicide, and possible self-harm. So if this is a trigger for you, please turn off this slideshow and we will find an alternative way for you to complete the assignment this week as assigned. Okay, now that hopefully, if this was a trigger, someone turned it off, I will proceed. We're looking at the unipolar depression diagnostic checklist here, okay? So, with a major depressive episode, what's important to understand, I'm not going to read the whole thing because time, again, duration of a disorder according to the DSM is going to be important in diagnosing a major depressive episode versus major depressive disorder and persistent depressive disorder. So we'll see that with a major depressive episode, for a 2-week period, you have to exhibit symptoms of depressed mood for the majority of each day and or decrease in enjoyment or interest across most activities for the majority of the day. And in those same 2 weeks, you also have 3 or 4 of the following symptoms. Considerable weight or appetite change, insomnia or hypersomnia, so, not being able to sleep or sleeping too much, agitation or decrease in motor activity, fatigue or lethargy, feelings of worthlessness or excessive guilt, reduction in concentration or decisiveness, so you can't make decisions as well, repeated focus on death or suicide, a suicide plan or a suicide attempt. Again, this is not always the case. You can be depressed and not have suicidal feelings. Okay, so I just want to make that clear while we're going in and tying in a little bit about suicide in this lecture. And this causes significant distress or impairment to the person because they can't function in their social life or in their daily life in executing out their job or their education or other responsibilities. And so you'll see that the DSM, you're kind of like, well, how do we diagnose this in someone? That's the job of the therapist. I want to remind you as we go through this checklist because it seems very subjective. And in part it is. And we've seen there is some controversy with the DSM if we refresh way back to, I think, Chapter 3. So keep that in mind. It is how the therapist interprets the person's symptoms, what information they're pulling from the individual, and what the individual is conveying. So, now that we know what a depressive episode is, we can build on that to understand major depressive disorder. Major depressive disorder. The big difference between major depressive disorder and persistent depressive disorder is going to be the presence of a major depressive episode and no pattern of mania or hypomania. So, mania this is a feeling of extreme euphoria. Okay? So, hypomania is hypo meaning under. Usually that means under. Hypomania is like having feelings of mania but are not true manic euphoric feelings, but you still have kind of that episode, right? So that's understanding mania and hypomania. You see where it gets a little fuzzy in diagnosing those and why the DSM is so heavily critiqued? A major depressive disorder is when someone has a presence of a major depressive episode, as listed on the previous slide, those symptoms. Persistent depressive disorder is going to have someone who has symptoms of major or mild depression for at least 2 years. So that is a long duration of time, hence why it's persistent. And during that 2-year period, symptoms cannot be absent for more than 2 months at a time. So they may kind of ebb and flow out of depression, like maybe they'll have like a good few months where they've been depressed and then they feel like they're not depressed anymore and then the individual falls back into depression. That will happen. but it can't be for more than 2 months at a time in between those bouts. And they have to have no history of mania or hypomania, because any instances of mania or hypomania is going to fall under bipolar disorders, because you're switching from opposite ends of the spectrum. And we're going to discuss what I just said in depth. So it's not like people use the term bipolar thinking you flip back and forth really quickly. No, it's a longer duration of time. And again, these are going to cause significant distress or impairment to the person. Now I want to take the time to discuss suicide. Sorry, the email caught my attention. Suicide, we're not reading the chapter on suicide just because I felt like I could tie it into depression a little bit. But suicide is going to be self-inflicted death in which a person makes an intentional, direct, and conscious effort to end their life. Okay? Suicide can happen for so many reasons. A lot of, it can be tied to depression because, again, depression is your cognitive functions are limited. And so people who commit suicide or attempt suicide are often not in a quote-unquote right mindset. There are a lot of things going on in their lives that kind of can compile themselves, and if that's coupled with something such as depression, it may facilitate or will make them want to carry out suicide. Some quick stats. One of you in your introductory paper listed some suicide statistics, and I was really impressed because they were spot on. I didn't know if you looked it up in the book, but people who attempt or carry out suicide are most likely to be socially isolated, so they don't have the social support structures in place that we emphasize so often, in coping with different psychological disorders. Women are 3 times more likely to attempt suicide, whereas men are more likely to carry it out. So what usually, this is attributed to men using more instantaneous means to complete suicide, such as weapons as guns, whereas women are more likely to engage in methods that maybe take a little longer, so the odds of kind of stopping them are greater or saving them are greater, such as like poisoning or overdosing on medications. Not saying that you can be saved every time, but men tend to use methods that are quicker, so to speak. Religious affiliation has been attributed to lower levels of suicide, so people's level of devoutness to their religions, especially when the religions preach the sanctity of life, are less likely to carry out suicide. And different rates of suicide can vary based on social circumstances, so race and sex. So as we see between male and female individuals, there are vastly different amounts of suicides. And this graph on your right is going to represent suicides that are carried out, so not attempts. So you see the great disparities between male and female individuals, as well as different races. Okay, and different social circumstances can kind of lend themselves to whether someone will commit suicide or not. There could be triggers, there could be compounding factors, such as current events, if they've taken them in enough or stressed out enough about them, that can be very detrimental to their psyche. Conditions in their life, if they have any long-term stressors, like maybe a medical illness they've had for years, or, taking care of a loved one who was recently passed, changes in their mood or thoughts, if they're using or abusing substances, mental disorders, or news of another suicide. So typically what we see with suicide that are carried out is kind of like a copycat effect. So unfortunately, sometimes when suicides are carried out at a school or an institution, someone commits suicide, we find that other students or people do it later. It's in part because it's a little bit of social learning theory. They kind of observe how that person is remembered and want the people, it could be they want the people to have the same remembrance of them and make them feel bad for, bullying, for example. It's a tough subject to talk about, but Sometimes people copycat because they want the same kind of memorial. They want people to feel bad. Or they think like, oh, look, they did it. I can do it. Like, I can carry it out. It's horrible. And so it's important to understand the triggers and the warning signs of suicide. Because we really try to initiate preventative means, to try to kind of swoop in before anyone can execute any self-harm or attempts. And so this is done through crisis intervention or long-term therapy. So if someone stopped from making a suicide attempt, you can't stop it once it's been completed, because that's not, that's the suicide has been committed. But if you intervene with someone's suicide, it's important to get them to long-term therapy so that they can work through their issues in the long term. They need to consistently address the triggers in their life so that they may not do this down the road. Common predictors of suicide, I've included a list from our text that's really important to understand, because you'll see how suicide is so related to depression. We see depressive disorder, alcoholism, and other forms of substance abuse. Sometimes people die from, overdoses, and people attribute it to an overdose as opposed to suicide, but sometimes there's no way of knowing. Prior suicide attempts, social withdrawal, isolation, living alone, hopelessness, impulsivity, being an older white American male, modeling suicide. Of course, that not in and of itself is more likely to have someone have a predictor of suicide, but that tends to be the highest rate, highest demographic. Suicide in the family, someone models that behavior. Anxiety, stress, and stressful events. There are a lot of triggers. I've also heard, which I would have to check the ethos of, that when people who struggled with depression suddenly feel all better and they start giving away their stuff. That could be another warning sign, because they're trying to unload it before the process occurs. So if you notice any of these predictors of suicide in someone, you're never being too careful. It's always good to ask or call the Suicide National Prevention Hotline, because that hotline will give you information for not only you, but for other people or for someone you know. And I've included links to those resources in our supplementary resources folder. You'll find a depression inventory, so you can kind of screen yourself if you feel like you've been struggling with depression. There's also resources for the National Suicide Prevention Lifeline, and different things about their webpage and resources available to you, as well as videos explaining more about depression and suicide. But again, remember that depression is not always a result of suicide, okay? There are some people who are depressed who do not exhibit suicidal ideations. But it's important to be aware of. So I've included those links in your folder. Please check them out, and I'm going to finish with part 2.